Good evening to one and all. We'll start our monthly meeting today. I kindly call upon our President, Dr. Sendilvelu sir and Dr. Arvind to the stage. Let's start with caller adorning. I kindly call upon Dr. Arvind for Marthuvar Prarthane and IMA prayers.
Good evening. I request everybody to stand for prayer. மருத்துவரின் பிரார்த்தனை. எல்லாம் வல்ல இறைவா, உலகின் சிறந்த மருத்துவன் நீயே. உன்னை மண்டியிட்டு வணங்குகின்றேன். உன்னிடமிருந்து நல்லதும் சிறந்ததும் என்னை அடைய பிரார்த்திக்கின்றேன். எனது கரங்களுக்கு திறமையை தாரும். எனது மனதிற்கு தெளிவான பார்வையை தாரும். இருதயத்திற்கு இரக்கத்தையும் கனிவையும் தாரும். எனக்கு அளிக்கப்பட்ட சிறப்பு தகுதியை தக்க வைக்கும் எண்ணம், வாடும் மக்கள் படும் பாட்டினை சிறிதளவாவது போக்கிட ஒன்றுபட்ட எண்ணத்தையும் வலிமையையும் தாரும். எனது மனதிலிருந்து தகாத எண்ணங்களையும் உலகளவு ஆசையையும் அறவே ஒதுக்கி பணி செய்திட அருளுமாறு குழந்தை போல உன்னை சார்ந்து வேண்டுகிறோம். இந்திய மருத்துவ சங்க வேண்டுதல். எல்லோரும் மகிழ்வுடன் வாழ, எல்லோரும் நலமுடன் வாழ, வலி என்னும் தொல்லை நீங்கி, அல்லல் செய்யும் இன்னல் நீங்க, பேராசை பிரதிபயன் அகற்றி பிணி போக்கும் பெரும்பணி ஆற்றுவோம். தேங்க்யூ. தேங்க்யூ.
We call upon our President to give the presidential address.
Good evening, one and all. Warm greetings from Erode IMA. So this last April month went on well. So along with our state IMA, we conducted several programs like World Autism Day, where we took a good support from pediatric team, Dr. Sivaraman. Along with Dr. Sivaraman, we gave a health education in the IMA hall, nearly for special educators, nearly 200 special educators participated in the whole Sunday program. And Dr. Mallige Silvaraj, she conducted a rally for the physically challenged children on the World Autism Day, along for which our district collector came for the rally. And World Earth Liver Day was conducted, and the World Earth Day we did a tree sampling at several places in the Erode. And we conducted the World Malaria Day along with our members, Dr. Nandakumar and Prasad. And Erode IMA, along with the state IMAs, this year motto is to village adaptation program. So Erode, near surrounding villages, we've taken nearly 5 villages where the camps were conducted, where the health screening, like eye screening, and several screenings were conducted. For the needy patients, iron tablet supplements were given along with the woman doctor wing. And we did 4 places. The village adaptations program was conducted. And every Tuesdays we conducted, because our Tamil Nadu Timacon state conference is coming. We are the host. We are hosting coming December. So we request all the members, Erode members, to kindly participate. We are having 1,500 members. Please participate it. Please register and come. So where we are getting 6 IMA credit points are there. As Tamil Nadu Medical Council nowadays is, everybody needs, we are emphasizing on the credit hours. Above 65 to 70, only 15 points required. Above 70, no credit hours. Rest all required 60 credit points. Every program, if you attend the meeting, Erode IMA helps, we get 1 credit points, and we are sending the links for the Zoom meeting. Those who doesn't have a credit points can attend the Zoom meeting and can get enriched with the credit points. This month meeting, we welcome the I Foundation team, where we are going to have an excellent talk along with our Dr. Diabetic program by Dr. Sindhuvel sir. Long live IMA. For last every association we did a membership strength. This month Yeah, we are having an excellent reduction. Nearly 15% reduction is there for the life members' fees, for the couple members as well as single members. So please request your friends to become IMA member and help us. Thank you. Long live IMA.
Let's move on to the Secretary's report. As most of the events has been brushed up by our President, I'll just go through the slides. Last month, nearly we conducted 15 events, starting from World Autism Day, NHP meeting, World Health Day, and Village Adoption Program, Monthly CME meeting, World Liver Day, Village Adoption Program, and World Earth Day, and MAM Visit, and World Malaria Day. The first event started with World Autism Day, conducted by Dr. Mallika Selvaraj. A rally was arranged, nearly around 150 members participated, and it was from Collector Office to Erode IMA Hall, which was waved off. Flag was waved off by our district collector. This was followed by a meeting and appreciation of the workers who were taking care of these specially disabled child. This was the first NHP meeting that was conducted on April 3rd, and a crisis that has happened in a private hospital was managed well. Nearly the problem was diffused with the help of all the IMA members, and I kindly request all the members to keep the documents updated and everything ready, so that it will be helpful for the team to have a discussion with other people. And we had a very good support with our IMA audit advocates and local police also. The problem was easily diffused, and there was no damages were there. This was the second NHP meeting that was conducted on April 6th. This was the World Health Day that was celebrated. This is the World Autism Day that was celebrated by the Erode Pediatrics Association. In continuation with the village adoption program, Erode IMA regularly conducts programs, and this month it was a village was adopted by Women's Doctors Wing, conducted by Dr. Chitra Tangvel ma'am and Dr. Sendilvelu sir. This is the last month CME program. Nearly 170 members participated. World Liver Day, which was celebrated at Kumaran Gastro Center. A village adoption program that was conducted by NGO organization near Chittoor. Nearly this organization is actually nearly around 200 farmers were participated in this health awareness program. This is the World Earth Day. We celebrated by planting a tree. MAM visit was done on 4th, and this was World Malaria Day, celebrated on 25th April. Blood donation. Regularly our Chitra madam is doing blood donation, and nearly around 150 bags was collected on the day. This month we have three speakers from four speakers from I Foundation and one speaker from Maruti Medical Center. I welcome our senior consultant Dr. Sendilvelu sir, Dr. Suresh Babu from Erode I Foundation, and Dr. Vijay Kumar from Erode I Foundation, and Dr. Shakti Rajeshwari from Erode I Foundation Hospital. I also welcome Dr. V.B. Rajavel sir to have a talk with us regarding our health and humor. Thank you. Call upon our first speaker, Dr. Sendilvelu sir, to talk about diabetes reversal, remission, and realities, and update.
Very good evening, respected senior colleagues. I am a President, Secretary, Finance Secretary, and senior physicians and all office bearers and my dear friends. First of all, I thank IMA for having invited, along with the I Foundation, for giving me the opportunity to share and present the views about the latest trend going on all over the country as well as the world. Is it possible to have some insight about diabetes management? Because right from 1990, we are keep on projecting the presentation, and every 10 years we are projecting the data of how much diabetes we are increasing every decade. Based on that, our diabetes treatment strategies along with ADA and ICMR and RSSDA, we are promulgating a lot of guidelines to treat. For the past 3-4 years, new interest is brewing, stating that is it possible to reverse diabetes. Followed by many ideas, many concepts evolved from keto diet, from restricting the drugs, and what many points in India saw is many people got dejected by buying medicines, continuing diet and exercise, so suddenly they stopped. So after stopped, when few are interested to follow diet and exercise, to the surprise, some of them, when they come to the hospital, their sugar level was not much increased. A1C was in a same line. Even though there are subtle differences exist, there was some opportunity to look at that. There is a possibility that diabetes remission is possible. Sometimes with metformin, sometimes with insulin, sometimes with strict diet. So these all led world over key scientists and researchers, especially in UK, to again bring forward the concept of reversal, remission, and what is the reality now. Putting together for last 10 years of work all over the world, I just put a snapshot. Maybe it is not complete. For 20 minutes, you can have some interest to look at this. ஏன்னா இப்போது நமக்கு தெரிஞ்சதை விட நம்ம பேஷண்ட்ஸ் நம்மளை டெஸ்ட் பண்ண தான் வர்றான். சார் ரிவர்சல் இருக்குது தெரியுமா அப்படிமா. நம்ம இதை பற்றி அப்படிங்களான்னு கேட்டக்கூடாது, அதான் தெரியுமே அப்படின்னு சொல்லிடணும். ஸோ ஃபார் தட் வி நீட் சம் டேட்டா, சம் இன்ட்ரெஸ்ட், சம் பாயிண்ட்ஸ் டு டேக்கிள் தெம். இப்போ கேஷீட்டெல்லாம் முன்னாலேயே பார்த்துட்டு நாம் கொஞ்சம் கூகுள் பண்ணிட்டு தான் பேஷண்ட் பார்க்க வேண்டியதாக இருக்குது. இல்லைன்னா நமக்கு மேலே டேட்டா அவன் கொண்டு வரான். So we have to prepare. Now the new era, we have to take care, we have to strategy planning and challenging. So in that, how this diabetes global epidemic and pandemic also is looking at it. Because in all national level, regional meeting, we see at least 1 to 2 hours of debate and concepts about reversal and remission all over the country as well as in the world. So these projections ever increasing. We just have a backup data that there is always increasing and over exceeding the projections calculated by the epidemiologist. So now they project that 48% increase is expected by another 20 years. It's almost we are topping many, you would have seen in all WhatsApp groups that India is exceeding the China in the numbers. It's almost, we are equal. So what we are, again, this is the classification, just a recap. Diabetes as such has 4 divisions. Type 1, we all know, type 2. And this gestational diabetes is again increasing. By and large, there is around 12 to 15% incidence, even in young age, around 20, 25, we see a lot of GDM much earlier. So what we predict and talk to the patients is, it's all in the IGT category. Pre-diabetes, who become pregnant, when we screen even the first trimester, even at 8 weeks, even at 6 weeks, they become diabetic. And we see at least pre-diabetes stage in GDM also. And then diabetes due to other causes, including MODY, some genetic predisposition, other LADA and other things. So coming to diabetic remission, the definition is again achieving glycemia below the diabetic range in the absence of active pharmacological agents or immunosuppressive medications or any ongoing surgical or procedures like repeated replacement of endoluminal devices, that is balloon and other devices you put to prevent obesity as well as diet consumption. So a remission can be characterized as partial or complete. The video click பண்ண முடியுமா? The video மட்டும் click பண்ணணும். நெட் இருக்குங்களா? This is what the Pride group in UK, they've put a movie, they designed this movie to motivate people in UK to bring them as volunteers. And after completing the trial also, they wanted to show, to see is it possible. So they put a small video in YouTube. Yes. So just it's a patient education program as well. So you know that insulin resistance, that leads to inefficient use of insulin and producing diabetes. So rather than concentrating on replacement and adding insulin, diet and medicines has to be re-looked at. So scientists looked at the other outputs like liver and pancreas, where the problem is the basic fundamental deficit. So they looked at it and this is the basic of direct trial. So they wanted the volunteers to come forward and undergo the low-calorie diet as well as the intensive group. So insulin can be enhanced, fatty liver can be reduced, insulin resistance of the liver itself can be modified. So that ultimately leads to blood sugar level which reduced and medications were stopped and he was in remission. So as usual, he was healthier, he was able to carry out all his work, back to work, and other complications because of weight reduction was reduced, including heart disease risk and fatty liver risk. So all these things are possible. Not only the diabetes was reversed, but as well the end organ damage was much postponed. So by at least 6 years, the reversal was possible. So weight management was the basic protocol, which they aimed almost 25 kg of weight loss was the maximum. They tried to finish the trial in 1 year. So mainly to stay in remission, for insulin to work better, that weight reduction should be sustained and it should be continued. So across all ethnicities it is possible. So make remission a reality. It is not only the Western world dream. So they want to bring the entire world into this scenario. That's all. So this is a diabetes UK's initiative they pride. Yeah, stop it. மேலே ஸ்டாப் பண்ணிடுங்க, மேலே இது பண்ணிடுங்க, அது உள்ள போய் நான் கீழே வந்துடுங்க, இன்னும் கீழே அதான் நெக்ஸ்ட் ரைட் நான் போட்டுக்கிறேன். So again, just to recap about the definition of remission for diabetes, the ADA has put some consensus on that partial remission where patient is no longer having diabetes, both A1C less than 6.5 and fasting blood glucose 5.6 to 8.9, 6.9 millimole without diabetic medications, time not specific, so maybe 6 months, maybe 2 years. So this is at least maintained for 1 year. And complete remission is possible when HbA1c is again less than 6 and fasting sugar 0.56 and less than that maintained for 1 year. But Buchwald and et al., another research group, find out that HbA1c, if it is less than 6, without anti-diabetic medicine also can be considered as without time duration. Even for 3 months it's beneficial, even for 6 months, even for 2 years. So other proposal they were made it to bring into the coding routine is those who have previous diabetes by WHO criteria with A1C less than 6.5, fasting sugar less than 7. It's reasonably slightly higher. Along with that, after at least 2 months without diabetic medication. So by and large, when you want to do implementing the remission, diabetes should be controlled, A1C less than 6.5. You stop medicine for 2 months and then it can be maintained for at least 2 months and later. And the criteria by the UK Primary Care Diabetes Society as is weight loss is very important, primary focus. And followed by fasting should be less than 126 milligram, A1C less than 6.5. And attaining these glycemic parameters after complete cessation of all glucose-lowering therapies. After 2-3 years, recently they modified this as you stop all other medications except metformin. So they don't recommend to stop metformin. At least 1000 milligram of metformin you can continue. So that the benefit of insulin sensitization and weight maintenance and prevention from progressing from reversal to at least IGT is possible when you continue metformin. So this again focuses on A1C number 1 less than 6.5, fasting should be less than 7 millimole or 126 with CGM data, HbA1c at least more than 3 months it should be sustained less than 6.5, and we also test along with HbA1c the complication screening, whether at least for 1 year there need not be any complication manifesting or new occurring. So why this question of necessity came for looking at the concept of diabetes remission and reversibility. World over, newer medicines are coming, at least 70 generic compounds are there. UK, not like India, unlike India, UK bears all the costs. Majority of 90% medicines are free. So they want to cut down this spending of 22 million pounds to anywhere, whatever they want to reduce, it's beneficial for them. So the average annual medical cost in US is also very high, $6,414 in 2007, and it is $9,061 recently. It's almost 2.5 greater than people without diabetes. So almost 3 times the spending of medicines cost of diabetes follow-up is higher world over. So yet the inadequacy of these costly therapies is evident when we look at the failure rates and people with uncontrolled diabetes. In whatever medicine they take, the complications around 40 to 50%. So even the India recently conducted study shows almost 70% of people are uncontrolled. Whether they are on many medicine, 2 medicine, insulin, whatever it is, the control is still very, very difficult to maintain for more than 50% of patients. So it's possible if you carefully follow the diet restriction, exercise and follow. The mechanisms are again weight loss by diet, either keto diet, exercise, bariatric surgery. Sometimes insulin also helps for few months. Drugs acting on the incretin pathway, GLP-1 receptor analogs and DPO inhibitors. These are all initially proposed, and remission with lifestyle interventions the number 1. Reduce carbs, thereby you reduce the insulin circulation need, then reduce the liver fat, reduce insulin resistance. Along with that, when you reduce carb intake, weight loss is achieved, again insulin resistance is reduced. It automatically reduces the reduction of pancreatic fat when the circulating insulin reduced by making more exercise and reducing the carb intake, ultimately leads to increased insulin secretion and reversing type 2 diabetes. So this is the basic. Type 2 diabetes, VLDL, liver fat is increased, pancreatic fat increased, beta cell dysfunction occurs. So when you reverse it or you make remission for at least 6 months to 2 years, liver fat decreases, liver fat export is decreased, pancreatic fat is decreased, beta cell function enhanced. So this is a direct trial. What we saw is the majority of evidence world over took from this direct trial, where this trial shows remission of type 2 diabetes with dietary and lifestyle intervention. So it's designed to see that type 2 diabetic patients with previous 6 years duration of diabetes. Why 6 years? At the time of diagnosis, 50% of beta cell is lost. Another 6 years, another 25% lost. So we presume that when you look at the type 2 diabetes patient, you include after 6 years, only 25% of insulin is reserve is present. So we tried to maximize the benefit by this trial by including those patients who have only 25% insulin. Age 20 to 65, BMI 27 to 45, endpoint 1 year later with at least more than 15 kg of weight loss, and diabetic remission with A1C less than 6.5. And after 2 months at least 2 months without diabetic medication. So this is a study designed intention to treat population were identified. Initially, patients were counseled, educated, primed to understand the need for remission, and they were all equally counseled to identify the same intention to get treated, followed by control group and intervention group. Total diet replacement, that is 825 to 853 kilocalories were advised for 20 weeks. Then food reduction after 22 to 8 weeks. Weight loss maintenance was observed at 52 weeks. So the result shows that weight loss of more than 50 kg was achieved in 24%. So 24% is 1/4 of the volunteers were showed very good reduction. Another 46% were showing DM remission. Another 74% showed drug discontinuation. So altogether, if you see, the intensive intervention group showed very positive outcome, and mean change in weight is almost 10 kg overall in the intervention group and only 1 kg in the maintenance group. And mean change of A1C was 0.9 in the intervention group, and control group only 0.1 increase was seen. So concluding the trial, type 2 diabetes up to 6 years duration can be reversed for weight loss and help of an evidence-based structured weight management program delivered in a community setting by primary care staff itself, routine primary care. Only almost quarter of participants who followed intervention achieved 15 kg of weight loss. So it is not a big dream or very difficult task to achieve. 1/4 of them achieved within 1 year. Almost half of patients in the intervention group showed remission of diabetes and were off anti-diabetic medication. So this is all the other incident of remission during the diabetes and aging study. Almost the same thing achieved. This is a very big people examined across 122,781 adults with integrated healthcare system. They were analyzed. Remission required is almost same. Partial, at least 1 year of subdiabetic hyperglycemia counteracted. Complete is at least 1 year of normoglycemia. A1C 5.7 to 6.4 subdiabetic, that is in the IGT range. Those A1C less than 5.0 normal level, they were treated as complete remission possible. And when they prolonged complete remission for at least 5 years, and the result shows 7-year cumulative evidence, partial, complete and prolonged remission was 1.47%, 0.14 and 0.07. So prolonged remission is very difficult to achieve, whereas 0.14 were achieved with complete remission, but almost 1.7% were achieved with partial remission. So that is a very good important change. And this incident shows that any remission was 1.6%. So adjusting this correlates, remission include age above 65, African American race, less than 2 years of diagnosis, baseline A1C. So no diabetes medication at the baseline. So in the community setting, remission of type 2 diabetes does occur with bariatric surgery also, but it is very rare. So surgery also you can contemplate if necessary. So this is the association of intensive lifestyle intervention with remission to examine weight loss intervention with frequency of remission from type 2 diabetes to pre-diabetes and normoglycemia was analyzed. Participants were randomly assigned to receive the intensive life intervention group, which included weekly group meeting and individual counseling for 6 months. 3 sessions per month for the second 6 months, 1 year duration. Twice monthly contact and regular refresher group campaigns for 2 to 4 years followed, which group offer 3 group sessions per year on diet, physical activity and social support. So these are all we can make it possible by taking into account and we practice in our clinical setting. So in conclusion is, analysis shows overweight adults, intensive life group arm individuals associated with greater likelihood partial remission. So when you compare to control, if intention is good, sustaining the counseling, group meeting, follow-up with diet, exercise and calorie restriction, it is still possible. However, the absolute remission is very difficult to achieve. So all these both trials which showed that direct trial and diabetes and remission and the latest one all showed diabetes remission and reversal is possible for at least 2 to 3 months to maximum 2 years. 5 years target is very difficult and it is not possible, so we don't tell our patients, we don't expect, we don't follow up for that year. But at least when you stop diabetes, when you give remission without drugs with good weight loss of 10 to 15 kg, definitely this leads to very good reduction in weight. So overall diabetes management is altered, drugs stopped except metformin. Metformin was continued and even now we encourage for some patients to continue metformin, diet, exercise. But 800 and 850 kilocalories continuation is very difficult for initial period. Maybe very few percentage they follow. So after 1 year, they reverse it to at least 1100 to 1200 kilocalories. So this is another short-term insulin. So apart from diet, exercise and intervention, there was one proposal they analyzed with short-term insulin therapy, those with IGT as well as newly detected diabetes where there will be glucotoxic. Even for them, if we give a short-term use of intensive insulin therapy, and these studies showed that 66% there was remission at least for 3 months. After 6 months, another 48%. So 1 year, 46% were showing remission. This is sometimes we call it as honeymoon period in diabetes. So we can utilize this and we can confidently stop insulin also when you carefully monitor, when the patient is ready to come for regular monitoring, have a glucometer at home, periodic checkup, adhere to exercise and diet. And this is about the remission, how much period, 9 out of 13 patients achieved in this. So this is how insulin induces remission. That is because islet cells who are over exceedingly depressed by insulin resistance, when you give a course of insulin, it gives rest to the islet cell of pancreas. So that again get regenerated over time with diet, exercise and insulin. That's what we saw. The pancreatic fat reduction and antioxidant effect leads to better recovery of insulin in the islet cells. So this surgery, we all know that after bariatric surgery, you get good reduction. இதை மட்டும் கிளிக் பண்ணிடுங்களேன். சாரி, அதை மட்டும் அந்த யூடியூப் நெட் இருக்குல்ல, this is how bariatric surgery can be put into a very good remission mode. This is all we know, but we cannot promote this to our patients because it depends on the patient's interest and our intention. So very morbid obesity you can try. There are also some post-surgical complications we cannot predict. So if patients are really interested, if they are very morbidly obese, then you can suggest this. கொஞ்சம் ஃபார்வர்ட் பண்ணி விடுங்க, கொஞ்சம் அப்படியே வச்சு ஃபார்வர்ட் பண்ணி விடுங்க, அப்படியே மூவ் பண்ணிடுங்க அந்த இதை. வேணாம், வேறு வீடியோ இல்லை அதில், எடுத்துருங்க, வேண்டாம். So this is about patient counseling part, that's all it is there. Cancel பண்ணிட்டு போயிருங்க. Yes, next, yes. So this is about how weight is being influenced after a bariatric surgery. Among the 103 treatment arms, about 3,188 patients reported a resolution of diabetes, about laboratory and clinical manifestation of type 2 diabetes. 19 studies with 43 treatment arms showed that weight loss and diabetic resolution was possible. So overall, 78% of diabetic patients had complete resolution, and diabetes was improved or resolved in 86% of patients. So weight loss is the first important cornerstone in achieving diabetic remission, and this is about the gastric banding, how remission is possible in type 2 diabetes. Almost 73% achieved, and participants randomized to surgical therapy were most likely to achieve remission of type 2 diabetes through very great weight loss. So the benefits of remission, again to recap, is for patients it removes personal and social stigmatism as diseased or diabetic. It provides target and reward for the sustained hard work usually necessary to achieve and maintain substantial weight loss, which may permit life insurance, mortgages, travel insurance without the higher premiums added to the people with diagnosed with diabetes. இது ஒன்று தான் இன்ட்ரெஸ்டிங்காக இருக்குது, அதுக்கு தான் ஸ்லைடே போட்டேன். ஸோ இப்போ உங்கள் பேஷண்ட்ஸ் யாராவது சார் எனக்கு இன்சூரன்ஸ் எடுக்கணும்னா டயபெட்டிக் ரெமிஷனில் இன்க்ளூட் பண்ணிடுங்க. 2 years ரெமிஷன், 2 years கழிச்சு இன்சூரன்ஸ் எடுத்துக்கலாம். This is the US perspective about mortgages also. They look at the weight and the health benefits of the person. So இங்கே இன்சூரன்ஸ் தான் ஒரு மாதிரி இருக்காது, அப்புறம் பேசுவோம், அது வேறு. பட் anyway there is a possibility. It removes occupational restrictions also. For epidemiology and health system, it identifies a valuable indicator of success in healthcare. National registry we can maintain. It allows better analysis of long-term morbidity and mortality risk. What does it mean is, if we know that patients' obesity is reversed, their diet is reduced with the right restriction, their exercise, they can at least postpone diabetes for 2 years. Definitely we can show that morbidity and mortality can be reduced further if they follow diet and exercise well, along with minimal medicine thereafter. That is a very important tool. I always insist them to follow. It improves resource requirement and forecasting. So now we again come back to the question of remission in type 2 diabetes. Is it possible? Short-term insulin therapy is what we have seen clinically, that in a glucotoxic patient we started with good analog insulin and metformin. We can predict in another 3 months to 6 months we can stop at least 3 months to maximum 9 months. So that we can motivate them, we can tell them that it is still possible. Bariatric surgery, definitely we are seeing for the past 1 decade. I see many patients who undergone bariatric surgery a decade ago, still very healthy, very active, but it should be very carefully assessed and then are recommended. With lifestyle efforts such as dietary intervention, weight loss, this remission with 850 to 883 kilocalories are still worth trying before advising, before deciding that weight management with diet restriction is not possible. So by conclusion, type 2 diabetes remission seems possible through intensive lifestyle changes, insulin therapy, as well as bariatric surgery, based on the current reviewing of literature. Further, larger studies are required to substantiate the same hereafter. Recognizing remission of diabetes can be a powerful motivator for patients to maintain weight loss. So this is a very important aspect, I always insist. So we have data, we have studies. So if you lose weight and if you continue to maintain the same weight for many years, there is always less requirement of medicines, less complication in the long run. So only time will tell if there will be an era where there is a cure for diabetes. Maybe stem cell therapy, other therapies are all in the way. Maybe it will take another 5 to 10 years to decide, is it really possible? So only one thing what I insist again is, now our patients are very, very clever. They are smarter with their smartphones, and their sons who are 23, 24 obesity, you will be surprised to ask them, they have personal dietitian. They have personal gym trainee through online. Everything they do on online. At least weekly 10 to 12% I am getting this response. Maybe if you ask them, they will tell you. Otherwise, they won't tell you. Many obese software persons who are ideally sitting and work from home are having online diet support. But they are being lured, they are being confused, they are not properly monitored and advised. Sometimes the dietitian maintains them in the obesity to get more money for many decades. Unless we know, unless we understand the need, unless we interact, update, we cannot talk to the deer. நம்ம அது காசு இல்லை, நம்ம தான் ஃப்ரீயாக சொல்கிறேன்னு நினச்சி அதை பேசுகிறதே இல்லை. So what I talk and I tell my all physicians and doctors is, time is money. You spend half an hour, you get 500 rupees. People are ready to pay. All MLM are successful in our region because they talk for hours together and get more money. See, we learn newer techniques. We get help from these newer techniques, newer ideas, which all youngsters believe. Only thing is that they don't get the desired benefit in long run. They get all diet benefits, but they are not able to sustainably without medical supervision. So unless we learn, we carefully analyze, we identify the bottlenecks of diet restrictions and follow up, we can achieve all this. It doesn't require much expertise. It requires only simple adherence, understanding and continuous perseverance. Thank you very much. Questions at the end.
Sir?
Questions at the end.
Diabetes reversal and remission. Sir, 1 minute. Sir. Photos. I kindly call upon Dr. Ravi Kumar sir to honor our speaker. There is a non-contact tonometer kept at the front. I kindly request all senior members to get their intraocular pressure measured if they are willing. I kindly call upon our next speaker, Dr. Vijay Kumar, Dr. Suresh Babu, to talk about diabetic retinopathy, an early indicator for renal and cardiac diseases.
Good evening, everyone. So, diabetic retinopathy, is it a herald of cardiac and renal disease? So, let's see. So, the pathogenesis of diabetic retinopathy is that prolonged hyperglycemia leads to all these metabolic pathways, that is protein kinase C, advanced glycation end products, polyol pathway, exosamine pathway, reactive oxygen species. So what they cause is they cause a lot of oxidative stress and inflammation, which leads to microvascular damage with loss of pericytes, blood-retinal barrier alterations, capillary occlusion, ischemia, neurodegeneration in the form of reactive gliosis, impaired neural function, neuronal apoptosis, which leads to diabetic retinopathy. The basic pathology is the same, whether it is nephropathy or cardiopathy. So here on examination, this is how a normal disc looks like. So there are a few dot and blot hemorrhage if you observe carefully. So these are the signs of diabetic retinopathy that we pick up. The cause for this is basement membranes are lined by pericytes. The loss of pericytes and basement membrane damage leads to these kind of hemorrhages, and capillary occlusion and ischemia leads to these whitey spots. We call them cotton wool spots in the nerve fiber layer of retina, and this leads to leakage of fluid from the blood vessels in the extraretinal space, leading to hard exudates and swelling of the retina. So the swelling of the retina we call so-called macular edema. Like I said, these blood vessels, they have these pericytes. Once, because of all the pathways that I said, there will be loss of pericytes, which leads to these aneurysms. These aneurysms leak fluid into extracellular space, and this leads to swelling called as macular edema. So the pathogenesis is more or less the same. Whether it is heart disease or kidney disease, ultimately what it leads to chronic inflammation and endothelial injury leads to atherosclerosis. In this, it leads to renin-angiotensin-aldosterone axis. So the pathogenesis in a cardiac event, like I said, because myocardial ischemia, because of blocked artery, ultimately leads to myocardial metabolic perturbations. So diabetic nephropathy as well, the hyperglycemia leads to the same metabolic process like in diabetic retinopathy as well. So diabetic retinopathy is useful in predicting diabetic nephropathy in type 2 patients and in renal disease. So it is shown that especially in advanced stages like in PDR, if we see any patients of PDR, the patient is more likely to have nephropathy as well. The same is as with cardiovascular disease also. So in advanced stages like in proliferative diabetic retinopathy, these patients are more likely to have nephropathy and cardiopathy. So it needs referral to a nephrologist and a cardiologist as well. So what is the importance of an eye examination? So it is the only visible vasculature, and there is increased vascular resistance, which leads to thickening of basement membrane, protein composition changes, and iron deposition. So vascular compliance was reduced in both large and small arteries in type 1 diabetes before clinically apparent microvascular complications. So these microvascular changes translates into macrovascular events. So when should a patient have a checkup? A type 1 diabetic should have an initial dilated comprehensive eye examination by ophthalmologist within 5 years after the onset of diabetes and annually thereafter. Type 2 diabetic should have a dilated comprehensive eye examination by ophthalmologist at the time of diagnosis of diabetes and annually thereafter. Gestational diabetes does not need ophthalmological examination during pregnancy unless diabetes mellitus is pre-existing. So the physician is the first point of contact of a diabetic to the medical system. All that is takes a simple indirect ophthalmoscopic examination which can be done at the bedside. So risk factors for diabetic retinopathy: long duration of diabetes, associated hypertension or dyslipidemia, higher BMI, smoking, associated kidney diseases, poor glycemic control, HbA1c more than 7.5, anemia. Remember, the risk factors are same for cardiac disease and nephropathy as well. So what do we see clinically? So this is the fovea, this is the optic nerve head. So we see thickening, that we pick this up on a 90D with the slit lamp examination. So with the 3D examination, we actually see that the retina is elevated from the surface, or we can see a few hard exudates at the center, or thickening and hard exudates more than 1 disc apart from the center of the fovea. So that was clinically. So we have a simple test in the OPD. This is how a normal scan will look, and this is how a patient with a scan of a patient with a diabetic retinopathy will look. So this is macular edema. We can see that how a simple scan beautifully picks up the swelling and subretinal fluid as well. So this scan gives us so much of information, in the sense that if we see dots like this and SRF, if a patient presents with SRF and dots like this, these are called hyperreflective dots, then probably the mechanism is inflammatory mediators are playing a role. So if the inflammatory mediators are playing a role, we can decide what kind of therapy the patient requires. So we can give local steroid injections. So fundus fluorescein angiography, this is how a normal fundus fluorescein angiography will look. And a patient with diabetic, these are all the microorganisms that are leaking, and this is a new blood vessels that is leaking profusely. So this we call a proliferative stage, and if the patient has gone into this stage, it is more likely that the patient has nephropathy and or a cardiopathy. So this is a stage when we see these kind of leaking vessels, then this means that we need to refer the patient to a nephrologist or a cardiologist for further evaluation. So what are the management options for diabetic macular edema? So anti-VEGF agents, we have ranibizumab, aflibercept, bevacizumab. These are all intravitreal injections that we give. We give implants like dexamethasone, fluocinolone and triamcinolone, laser photocoagulation, and surgery in the form of vitrectomy for vitreous hemorrhage and retinal detachments. So all these modalities are available at the center. There are a range of intravitreal injections that we give. These are anti-vascular endothelial growth factors. Ranibizumab, this is Avastin, is an off-label drug which is used for colorectal carcinoma that is injected inside the vitreous for controlling diabetic macular edema. The newer drugs are brolucizumab and aflibercept. So there are a range of drugs that are available now for intravitreal injection. So these are steroid implants that are injected inside the vitreous. So the advantage of steroid implants, this implant, is that it stays in the eye for a longer period. So the macular edema remission is seen for about 3 to 6 months. The anti-VEGFs, like I said, most of these drugs, the macular edema is for a month. The remission will be for a month. After a month, the edema may recur. Advantage of these implants is that Ozurdex implant, at least for 3 months, there will be a resolution of macular edema. So the laser therapy for unresolving macular edema or proliferative stages when the patient has proliferative diabetic retinopathy, and ultimately we have vitreoretinal surgery as well, the micro incision vitrectomy surgery wherein we enter the eye through 0.5 mm incisions, and then this is the treatment for diabetic vitrectomies for vitreous hemorrhage and tractional retinal detachment. Thank you.
Thank you, sir, for making the topic so crisp. I kindly call upon Dr. Vijay Kumar to talk about ocular manifestations of diabetes.
Good evening, everyone. I am Dr. Vijay Kumar. I am the Center Head of the Eye Foundation, Erode. I am going to talk about diabetic eye disease. So it's a privilege to be here on the stage in the Erode Indian Medical Association Hall in front of the doyens of healthcare of Erode district. And so what I'm going to talk about is what are the structures in the eye which gets involved in diabetes if it's uncontrolled, and what are the damages that can happen in the eye. So the prevalence of diabetes is estimated to be around 439 million by the year 2030. This is given by the International Diabetes Federation. With an aging population, with an advanced healthcare system where the patient's life is prolonged and the life expectancy is high by 33% by 2050, the morbidity with patients with diabetes is going to increase. So the diabetes can involve any part of the eye, starting from the eyelid. It can affect the tear film stability. It can affect corneal surface. It can cause glaucoma. It can cause cataract changes in the lens. It can cause diabetic retinopathy, as properly explained by Dr. Suresh. And it can also affect the extraocular muscle movements. So anterior segment changes include a simple meibomitis, which can cause recurrent stye in patients with uncontrolled diabetes. And this can also cause dry eyes. Because of the dysfunction of the meibomian gland, the tear film becomes unstable because of the lack of lipid layer, and which can cause further frequent redness and grittiness in the eye. This dry eye, if unattended, because of the reduced corneal sensation because of autonomic neuropathy and poorly controlled diabetes in unstable tear film, this can result in starting with an uninfected sterile ulcer, can get infected with fungus or bacteria depending on the immunity level, and this can permanently cause blindness and scarring. Looking at the iris, the patient can have a non-mydriatic, that is mydriatic resistant pupil, that is a mid-dilated sluggish pupil. This is primarily because of autonomic dysregulation in advanced stages of diabetes. In proliferative diabetic retinopathy, wherein there is a strong hypoxic drive, the neovascularization from the posterior segment can, the vascular endothelial growth factor can seep into the anterior through the pupil, resulting in rubeosis, that is neovascularization of the iris. These vessels in the iris are very leaky. This can present as glaucoma in later stages. In diabetic patients, in case of hyperglycemia, the patient can have increased myopic effect in refraction, while in hypoglycemia it can be hyperopic. This shift in refractive error can be so frequent that the patient might need to change glasses frequently just because of uncontrolled diabetes. So diabetes and cataract. The cataract in diabetes can be pre-senile, that is, at an early age patient can present with cataract, or it can be a sudden progression of already existing cataract changes in the eye. The patients with diabetes are 5 times more prone to develop cataract, particularly at an early age. Cataract extraction is one of the most common surgical procedures being done in general population, and it's, with advanced technology, even in uncontrolled diabetes, we have come up with excellent visual benefits now. Changes in corneal topographic parameters because of unstable tear film can be a challenge in estimating the intraocular lens power calculation during surgery. And in advanced cases where the cataract surgery can increase the possibility of progression of diabetic retinopathy and macular edema, ideally the patient needs a panretinal photocoagulation or an intravitreal anti-VEGF injection with the surgery or before the surgery to avoid progression of retinopathy and worsening of vision. Glaucoma is ranked the second most common cause of irreversible blindness, and around 11.2 million individuals above the age of 40 are suffering from glaucoma, and almost 90% of patients with glaucoma are unaware that they have glaucoma. It's a progressive optic disease wherein it has typical field changes because of gradual death of retinal ganglion cells. This can happen because of the increased pressure alone causing microvascular changes, or diabetic retinopathy being a microangiopathy can further worsen hypoxia and further cause damages to the retinal ganglion cells with rapid progression of glaucoma in case of uncontrolled diabetes. These are the typical optic nerve changes where they have a typical field defects which follows the horizontal meridian, and the visual impact will be gradual reduction in peripheral vision ending up with tunnel vision. Considering the common pathology of both the diabetes as well as glaucoma, early diagnosis is the most important thing to prevent complete visual loss. So it's a multidisciplinary approach from the physician to the ophthalmologist is essential to maintain or to prevent blindness through glaucoma. These are all the options that anti-glaucoma medications, laser trabeculoplasty and trabecular therapy with cyclo G6 is the latest in laser treatment for glaucoma. Gonio-assisted transluminal trabeculoplasty is another latest addition to the armamentarium of glaucoma specialists. This is a straightforward procedure which takes hardly 20 minutes to do, and the patient will have a benefit of up to 2 to 3 years of drug-free control of glaucoma. And trabeculectomy being the gold standard treatment for glaucoma is always there for all the patients who are not controlled with medications, or even with medications the glaucoma field changes progresses. Trabeculectomy is the gold standard of management. The patient presenting with double vision in diabetes is primarily because of involvement of third or sixth nerve, which is because of microangiopathy of nervosum, which affects, which causes infarct to that particular nerve, resulting in third nerve palsy or sixth nerve palsy. The primary difference between a neurological palsy and a diabetic palsy is it's a pupil sparing palsy, where the pupil reaction is spared. Thank you.
Now I kindly call upon Dr. Shakti Rajeshwari to talk about Z8 laser system, a new revolution in eye care delivery.
இதில் ஃபுல் ஸ்க்ரீன் வராது
மேடம், அதில் ஃபுல் ஸ்க்ரீன் இதில் வந்து நீங்கள் நெக்ஸ்ட் லைட் பர்சன்ட்னா இதில் மட்டும் நெக்ஸ்ட் ஆகும்.
ஓகே, வீடியோஸ்னால் இதுலேயே
அதில் நீங்கள் மூவ் பண்ணிக்கலாம்.
எங்கே மவுஸு
மேடம் இங்கே
வருமா?
இங்கே வீடியோ வரும்போது இந்த இடத்துல இந்த இது மாதிரி காசு மாதிரி.
Good evening, everybody. Today we are going to talk on a newer topic about Z8 laser system. Why we are here to talk about this topic today is like in the field of modern medicine, everybody is moving into, like we know we moved into endoscopies and laparoscopies. Likewise, we are moving into laser assisted surgeries and ophthalmology too. And it has been there in the previous years, and newer technologies are coming up, and we are now introducing newer Z8 laser system in ophthalmology. So what is the key aspects of this Femto Z8 key benefits is, so we are using a nanojoule laser technology in this, through which we has a wider range of applications in ophthalmology, which we would be seeing in the coming up slides. So instead of microjoules, we are using a nanojoule technology. Overlying pulse pattern creates a smoother and complete resection. So what everybody wants is a minimal invasive, minimal tissue handling and faster recovery nowadays. So this technology helps in unwanted tissue disruption, lesser inflammation and faster recovery. So in this picture you can see in the conventional laser systems, so we are using a high pulse energy and a low pulse frequency, which leads to larger focal volumes and high pulse energy spacing between the laser pulses, which leads to more side effects, and in results incomplete resections and inflammation and longer recovery time. So what we are applying in Z8 laser system nanojoule technology is low pulse energy with a high pulse frequency, which results in a smaller focal volume of laser application. Low pulse energy and overlapping spots are being emitted, so which results in complete resection with a lesser side effect and lesser inflammation. So though it has a lot of applications, we are today going to focus on only two common applications which we see in our daily practice. One is refractive error in less than 40 years age group. The other is persons coming with cataract in the 5th and 6th decades. So first we'll see into cataract. So the treatment, as you all know, for cataract surgery, for cataract is only surgical removal of the cataractous lens and placing an intraocular lens. So the evolution of cataract surgery, we started with ICC, intracapsular cataract extraction, then moved to ECC, extracapsular cataract extraction, and small incision cataract surgeries. And currently what we are practicing is phacoemulsification. So now the Z8 laser systems, this technology is being used in LRCS, which is laser assisted refractive cataract surgery. So this is animated video to show you the application of laser refractive cataract system. So the first video is manual blade surgery. The second one in the picture is the laser surgery. Play. Okay, play. So the first one is what we use to make the corneal incisions is using a blade. So the similar incisions in LRCS is made through a Z8 laser system, so which creates a very clear-cut incisions without blade. The second is we are making a side ports using a blade, which creates a straight linear incisions, whereas the incisions which is made through the laser system heals very faster without leaving any. After that, for removing the cataract, we make a capsule to do the capsulotomy technique with a needle. Whereas in case of LRCS, it is already being made by the laser, which is easily removed. And in the regular phacoemulsification, as you see with the phaco probe, we have to emulsify the cataract and remove, where we have to use more laser energy power to remove the cataract. Whereas in case of LRCS, it's all customized the laser itself cuts the lens into 4 or 8 or 6 pieces as we can customize it, and with minimal energy we can remove the cataract using the phaco probe, which is already cut by the laser. So lesser tissue inflammation and lesser energy inspection to the corneal tissues, so faster recovery. So this is a live surgery, the same one, phaco versus cataract surgery. So the initial video is like the first how we dock the patient and apply laser. It is a very simple technique. We just have to apply the cup over the patient's eye, and with vacuum it is docked and laser energy is being applied, and the laser energy goes and makes the corneal incisions, the capsulotomy, and also fragmentation of the lens, so which then the surgeon goes and removes with the phaco probe. And it's all an OCT guided system which is being customized and as per the patient's density of the cataract and the capsule. You can all enter the data, the sizing of the capsule and sizing of the incisions, and arc weight incisions can also be made for any residual refractive errors. So you can see the live surgery. The Z8 laser system has already made the corneal incisions and the capsulotomy and as well as fragmentation of the lens. So without using a blade, which is a completely bladeless surgery, the surgeon goes inside the anterior segment of the eye through the laser made incisions. So the already cut capsule is being removed, and the lens, which is already, you can see the already made capsulotomy is removed with the forceps. And using a phaco probe, we are going to go and remove the fragmented lens with less power and lesser energy, and in a very minimal period of time. So reduced working distance of this laser platform is enabled by the unique handpiece, and it allows for a larger numerical aperture which translates into a smaller focal volume of laser, which leads to more precise and gentler tissue separation. And as I showed in the video, it is completely an OCT guided imaging system. So it allows better visual control and live imaging between the steps of the cataract surgery as well as during the LASIK surgery. So you can do the surgical planning by the OCT imaging, and you can visualize it as the surgery goes on, and digital image processing with fully automated pattern recognition, and you have a geometric visualization of the plan trajectory based on the individual, and you can preset based on the patient's status, and intraoperative fine adjustments and customizations are made for ultimate control during the surgery. So as I said, we have a lot of applications in cataract as well as in cornea, LASIK, which we are going to see in the coming slides. As well as for corneal transplants, we can make a custom-made corneal tissue donor grafts also using this laser system. So coming to LASIK, as we all know, LASIK is laser in situ keratomileusis, which is a surgical correction for refractive errors. So whoever wish to get rid of glasses for myopia, hypermetropia, astigmatism, so we perform LASIK. So as we saw the evolution of cataract surgeries, LASIK also has evolved over a period of 2 decades. So we will be seeing in this animation slide. So initially we started with PRK, which is called as epilasic, photorefractive keratectomy, and then we moved on into LASIK. And then now recently we have moved on to a smile clear technique, which is based on the nanojoule technology. So the regular LASIK which we see, so the flap is created. It can be done as a blade LASIK. The flap can be created using a blade, or it can be done using a femto-assisted laser. After lifting the flap, we apply the laser for the power correction. After that, we give an interface wash and reposition the flap. So, what are the disadvantages of this is recovery is usually quickly, but 1 week flap healing time is there. So, the initial one PRK, which is epilasic, as I said. So, here we remove the corneal epithelium of around 50 to 60 microns. Then we apply the laser for the power correction. So, once the laser is done, we have to place a bandage contact lens over the cornea for the epithelium to heal. So what are the disadvantages is the recovery takes more time in case of PRK. So, and the patient has to bear with the pain, watering sensation and foreign body sensation for initial 3 to 4 days till the epithelium heals. So next came the smile technology. So here we are not removing the epithelium neither nor we are creating a flap. So we are applying laser which goes and creates a lenticule inside the eye, and the entry incision is also made by the laser. So we go with the microforceps, remove the lenticule. So recovery is very quickly, even from the next day you can get back to your routine activities. So this is animated video of the Smile Clear technology. So it uses a low energy to correct vision, therefore it is minimally invasive and a gentle procedure. So as I said, like in PRK, we are not removing the epithelium, and we are not creating a flaps also. So the laser energy is passed over the cornea, low energy laser, which creates a lenticular disc inside the cornea, and it creates a small opening which is also made by the laser. And we just, the lenticule is, we go with the microforceps through the incision and remove the lenticule, and the surgery is gone. The patient is left with a very clear vision even from the first post-op period. So this is a live surgery of the Smile Clear technology. So initially the docking is done. So first we dock the patient and apply the laser energy through the Z8 laser system. So you can see it goes and applies the laser, and it is creating the lenticule inside the cornea. The suction is on. Patient is very comfortable during the procedure, and the patient's cooperation is not much needed during this docking because it is a firm docking. And since everybody today is with a very busy, hectic schedule, everybody wants a faster recovery period post-LASIK and wants to get back to work very easily. And post-operatively, it is a very smoother recovery period. And you see live, once a lenticule is being done, so we are just going and creating the plane anterior and posterior of the already cut lenticule. It is a very simple technique. And the whole procedure is done only under topical anesthesia. No need for any regional blocks or for any anesthesia. You see, it is a very thin lenticule which is removed, and we just give a wash, and no bandage or anything. Patient is given with plain spectacles, and the patient leaves the hospital within half an hour. So just last one thing to mention, you would have heard of some people went to an ophthalmologist and they say you cannot get LASIK done. So for such patients, there is an option which is called as phakic intraocular lenses, where like how you apply contact lenses temporarily over the cornea, permanently, and phakic intraocular lenses can be placed inside the eye, which is a very simple technique. So a very small incision is made in the cornea, and the phakic lenses is loaded into the injector, and through the very small micro incision we just inject the lens into the anterior segment, and the lens is tucked under the iris in position, and the surgery is done. So those with high myopia where we cannot get LASIK done more than -8, or patients with a very thin cornea where LASIK is not possible, or patients with keratoconus. So where all LASIK cannot be done, patients can definitely go for phakic intraocular lenses and get rid of their glasses, and it is a completely safe procedure. Thank you.
Thank you, ma'am. The house is open for discussion. Call upon Dr. Suresh Babu to the dais. I kindly call upon Dr. Abdullah Sir to honor our guest speakers. I once again thank the Eye Foundation team for elaborating about the common ophthalmologic causes. Thank you, ma'am.
Our President-elect, Dr. Abul Hassan, today he has attended the nursing home beat, and from Karaikudi he has come all the way. So now he will address us some important valid points regarding the current trends.
Good evening. Good evening. So my dear friends, we are going to have a very important conference the end of the year. That is the TIMACON 23. That is a state level IMA conference going to be held on 8th, 9th and 10th, 3 days at Lakshmi Doraisamy Mahal and also D Wayfarer Resorts. And we have got a very dynamic team to organize, of course with all our support, to organize this very important event and very pride of Erode. This is the 4th time that IMA Erode is organizing a state level conference. This time little more unique and a little more productive and little more memorable. And I wish to introduce our organizing team with your big round of applause. Dr. Sendil Velu as the chairman, Dr. Parthiban is the organizing secretary, and Dr. Arvind is the organizing treasurer. And we have got so much of ideas we have held. We have added many of you in the organizing team, and we have started the process. And in addition, always it is held for 2 days. Now we want to organize for 3 days. The reason being, number one, we want to have more credit points. So we are going to start the academic event on the afternoon of Friday, Saturday, Sunday. We get six credit points in the one program alone. So the additional events we have planned on the Friday morning is an industrial visit. We have got so much of very well-known and also very popular industries in Erode. So we are going to take people from outside across the state to showcase one of our industry. So we have selected Milky Mist industry. which is, they're producing all milk products, including ice cream. So we have limited the registration for that up to 100. So 100 registrants will be taken to Milky Mist product industry on the Friday morning. There is another event on Friday morning is we are also conducting Premier League cricket tournament for medical colleges, intermedical cricket tournament. The semi-final and final will be held on Friday, that is 8th, in the Vasavi College ground. So you will see lots of youngsters, students throughout the conference. And we are having lots of programs for students also. And third day, we only have the state council. We will have the council for the students also, for the medical students network and the junior. This is the first time we are going to have it. And we are focusing on the issues of the hospitals in the conference. We want to mainly focus on the clinical establishment and its fallouts, Consumer Protection Act and its fallouts. And there are various biomedical ways and minimum wages act. There are so many things that are really, giving us problems. We want to allocate time for these subjects with the experts. So we need all your support and make this as one of the very protective, as I said, very protective conference. I want every one of yours participation in the conference, and many national level doctors leaders are coming. We have already established a brand that we will be doing a very reasonable, very decent conference. So this time also, first thing, on behalf of the organizing committee, I request that all the members of Erode IMA to register for the conference, and we have fixed the registration fee as 5,000 for the whole 3 days. And whoever wants to participate in stalls, in other magazines, advertisement also, welcome. And we have a budget of nearly 1.1 crore for the conference. So I think, being all our past presidents, senior IMA members are very interested and looking forward to have a very good conference. So with these few words, I invite on behalf of the organizing committee and my own behalf, because all know I have said everything except one thing. What is that? I am in that conference. I am going to take over as the President of IMA Tamil Nadu State. So I have planned to announce so many schemes, so many new projects on 9th of December. So many very path-breaking ideas we have, and you all will be part of various committees I am going to plan. Totally very new committees, and we are going to change the face of IMA in this, hopefully in the 2024, my tenure as the president. I have that hope I can do such changes with all are standing behind me. With all of you are standing behind me and supporting all these disruptive changes in IMA and also in organization, and also disruptive changes between the doctors and between the relations between the doctors and the government, relations between the doctors and the media, and the relations between the doctors and the police. All these things will be changed, and we have such wonderful programs with your support. So once again, I invite all of you to 100% without fail participate in this mega event. Thank you very much.
Thank you, sir. I kindly call upon Dr. V.B.R. Rajavel, sir, for give a talk about humor and health.
First of all, of all, I thank Dr. Parthiban for inviting me. You may be wondering what is the connection between this topic and because we failed to celebrate World Laughter Day. That is why they have arranged for celebration this combining with this IMA meeting. And actually we all know humor, how it is effective, how it helps to maintain us healthy and everything. Just I want to remind you some of the things you already know. Actually we started a humor club in Erode 20 years back, and so far we have conducted 225 meetings. Actually we planned to start in the IMA itself, but as there was no response, we started outside. And every month we are conducting a meeting and inviting a top speakers to address something humorous. And actually I have to dedicate this talk to Dr. Ram Murthy, our senior dental surgeon, who was very famous for his jokes. And wherever he was, he used to make this place very funny and joyful. Still I remember one of his jokes. He was working in GH, and everybody must be knowing his humorous attitude. And he used to visit all the departments and make all the doctors to enjoy with his jokes. As you know, in government hospitals, all specialists will be posted during as night duty medical officers. And once upon a time, an ENT surgeon was in the duty, and he was sleeping as usual in the night duty. And the senior nurse came and told him, "Sir, you have to attend a case. Just we have delivered a baby and we have done episiotomy. You please come and suture it out." He was in, the surgeon was in half sleep, and he came and he sat on the stool and held the speculum in the left hand, and he said, "Nalla vaai therande naganitama," அப்படின்றார். But it was an episiotomy. So even for, not only for health, even for learning, remembering, and teaching also, humor is very much important. We all attend all the classes of humorous teachers very well since school days and college days. During our medical curriculum and I think our surgery professor was teaching something. It was a post-lunch session, and everybody was dozing. And the surgeon was teaching. There are two schools of thought. One school advises surgery, and the other school advises medical management. And then he stopped and asked my neighbor, "What, Nararajan, which school do you belong?" And he asked me, what is he asking? I was also dozing, so I don't know. So I said, he asking, which school do you belong? He suddenly stood up and said, "Rangamal Higher Secondary School, sir." Those who understood the joke, those who were awake, laughed, and others didn't know what is happening here. And after the class, we all shared the joke very much. In 1964, Norman Cousins, he wrote a book on anatomy of an illness as perceived by the patient. He was suffering from ankylosing spondylitis. We all know this is a very dangerous degenerative disorder, and the doctors gave him only a few months to live. But what he did was, he used to take a heavy dose of vitamin C, and along with that, he continuously laughed for 10 minutes after seeing some comedy movies and television shows. Every 10 minutes of laughter gave him 2 hours of pain relief. And he was continuing that for a long time, and he lived for another 25 years without much pain, and he had a better sleep. That is the power of humor. After that, so many research papers came, and everybody proved that humor is very effective. And there are positive and negative emotions in our life. Negative emotions like fear, anxiety, greed, and so many negative emotions, these all elevate the cortisol levels and also catecholamines and everything, But positive emotions like humor and joy, they decreases these hormones and improve endorphin levels and give pain relief, and the negative emotions always cause vascular endothelial dysfunction and CAD and whatnot, you all know already. But this positive feelings like belief and laughing, they nullify these negative hormones and improves our health. Where to get this humor? Humor is everywhere, and you can see in all WhatsApps of social medias and everything. But if you talk to your children, whether it is your children or grandchildren or neighbor children, you will get lot of jokes. I used to talk very freely with my sons. I think when he was studying 5th standard, at the time the Maruti car was released, and I thought of buying one car, and I was telling him that I am going to buy one Maruti car. He just laughed. Then I was doing general practice. So, எங்கப்பா 10 ரூபாய் 5 ரூபாய் வாங்கி நீங்கள் எங்கப்பா மாருதி கார் வாங்க போகிற அப்படின்னு சேலஞ்ச் பண்ணான். சரி நான் கார் வாங்கிறேன்னா நீ ஃபஸ்ட் ரேங்க் வாங்கி கேட்டேன்னு 2 பேரும் ஒரு சேலஞ்ச் வச்சுக்கிட்டோம். அப்போ கார் வாங்குறதுங்கிறது ரொம்ப கஷ்டம். காருக்கு கொலேட்ரல் இது லேண்டு கொடுக்கணும், நிறைய பேங்க் ப்ரொசீஜர் இருக்குது, பேங்க்லலாம் ஃபார்ம் ஃபில்லப் பிடிக்கணும், இதெல்லாம் பார்த்துக்கிட்டே இருந்தான். அப்புறம் ஒரு வழியாக லோன் போட்டு நான் காரெல்லாம் வாங்கி கொண்டாந்து நிறுத்திட்டு அப்புறமா நான் சொன்னேன், நான் கார் வாங்கிட்டேன், நீ ஏன்னா ஃபஸ்ட் ரேங்க் வாங்கலின்னு கேட்டேன். அவன் சொன்னான், எனக்கு மார்க் லோன் கிடச்சிருந்தா நானும் ஃபஸ்ட் ரேங்க் வாங்கியிருப்பேன் அப்படின்னா. இந்த மாதிரி குழந்தைகிட்ட பேசுனீங்கன்னா நிறையா ஜோக்ஸ் வரும். என்னுடைய கிராண்ட் டாக்டர் இப்போ வந்தா, அந்த முடியெல்லாம் விரிச்சு போட்டு வந்திருந்தா, இது என்ன ஹேர் ஸ்டைல் அப்படின்னு கேட்டேன். இதுதான் ஃப்ரீ ஹேர் அப்படின்னா. சொல்லிட்டு பேசாமல் போக வேண்டியதானே. என்னை பார்த்து, தாத்தா உங்களுக்கு ஹேர் ஸ்டைல் என்னன்னு கேட்டா, எனக்கு என்னது ஹேர் ஸ்டைலுக்குன்னு, இல்லை உங்களுக்கு ஹேர் ஃப்ரீ அப்படின்னா. அது மாதிரி குழந்தைகள்கிட்ட பேசுனீங்கன்னா நிறைய கிடைக்கும். Several centuries back, the humor as a treatment was recognized, but I don't know why we people are following now. Even in Bible, there is a word that cheerful heart is a good medicine, and dried spirit and the crushed spirit dries up bones. Even in Bible, they have described it. After that, there are lot of research papers come. And also it improves the respiratory rate. 3 minutes of laughter increase the oxygen saturation and also the ventilation and forceful exhalation of pulmonary secretions. And during our college days, we would have enjoyed so many humors. And I think there are comedy of errors in English speaking. As we all came from poor village schools, I think during my second or third year, I was waiting in the front of, we are studying in Coimbatore Medical College, and in front of the college, we are waiting for a bus, and we were waiting with a stethoscope and quote our things. One gentleman, well-dressed gentleman came and asked, where is Rainbow Theatre? Actually, that Rainbow Theatre was in the same road as our medical college. It's 2 kilometers away from that. My senior was immediately shocked, and he couldn't answer well in the English. He said, you go and go, like that. He could not say that it is in the same road. And during intermedical sports meets, there was a dinner after the meet, and the ladies from other colleges were all serving. And one of my seniors wanted to show his English talent to the lady. And after taking sambar, rasam, he asked that lady, I want some more. She thought the rasam is very good, and she again put some rasam. No, I want some more. Again she poured rasam. No, I want some more. Oh, you mean buttermilk? Yes. இந்த மாதிரி நிறைய இங்கிலீஷ் காமெடிகள் நிறைய நம்ம பார்த்துருப்போம் காலேஜில். நல்ல a good laugh improves the heart rate, BP, sleep pattern and bowel movements. Patients also used to give a lot of jokes. I think Dr. Kandasamy has not come. Our senior physician in Karangalpalayam, once he was telling me that he asked that lady, நாளைக்கு வரும்போது சிறுநீர் கொண்டு வாமா டெஸ்ட் பண்ணணும்னு சொல்லியிருக்காரு. I didn't know what the lady understood. Next day she came after taking a good bath, and she came with இந்த விபூதி பை இருக்கு இல்லைங்களா, விபூதி பண்ணோம், அதை எடுத்து கொண்டாந்து டாக்டருக்கு திருநீர் விட்டுட்டாங்களாம். வாட் இஸ் திஸ்ன்னு கேட்டிருக்காரு அவர். அப்போ சொல்லியிருக்காங்க, நீங்கள் தானே வந்து திருநீர் ஒன்ற சொல்லிங்கண்ணா. திருநீர் இல்லைம்மா, நான் சிறுநீர் தான் சொன்னேன் அப்படின்னு சொல்லி அவர் இந்த மாதிரி நிறைய ஜோக்ஸ் இருக்குது. ஆனால் சம்டைம்ஸ் எனக்கே அந்த மாதிரிலாம் நடந்திருக்கு. ஒரு பேஷண்ட்டுக்கு ஸ்கேன் பண்ணுறதுக்கு முன்னாடி நீங்கள் சட்டப் பண்ணிலாம் கழட்டிட்டு படுங்க அப்படின்னு சொல்லிவிட்டு நான் மிஷின் அட்ஜஸ்ட் பண்ணிகிட்டு இருந்தேன். அவர் வந்து நின்றுக்கிட்டே இருந்தார். ஏன்னு கேட்டால், நான் பனியன் போட்டு வரலைங்களே அப்படின்னாரு. அப்படின்னா நீங்கள் கழட்ட வேண்டியது இல்லைங்களே அப்படின்னு. இன்னொருத்தன் நான் போய் பனியன் போட்டு வந்துட்டுங்களா அப்படின்னு கேட்குறான். இந்த மாதிரி நிறையா லாட் ஆஃப் ஜோக்ஸ் வித் த பேஷண்ட்ஸ். And also that humor improves immunity. Lot of antibodies are produced, and also disease fighting capacity is increased. And depression patients, the psychiatrist advice not to be alone. Always be with humorous people who could make you happy. In 1970, Patch Adams, he discovered that therapeutic clowning. He brought clowns to the hospital wards and make the people, and especially in the pediatric wards, they enjoy, and he proved the result was very good. And a movie, Hollywood movie also came, yes, Patch Adams. If you have not seen, please see. There are so many dark comedies about doctors. You might have seen so many jokes about doctors in the newspapers and WhatsApp. We have to take it as positive, and you should enjoy that. You should not worry about it. Once I saw a joke in WhatsApp. A 90-year man in a television interview, he was smoking cigars. And the interviewer asked him, see, already you are 95 years, but you are still smoking. Did not any people advise you to not to smoke? He said, எனக்கு அட்வைஸ் பண்ணவன்லாம் செத்து போயிட்டா டாக்டர்ஸ் அப்படின்ட்டு இருக்கான். எனக்கு அட்வைஸ் பண்ண டாக்டர்ஸ் எல்லாம் செத்து போயிட்டா அப்படின்ட்டு இருக்கான். இதில் நாம் சீரியஸாக எடுத்துக்கூடாது. அதே மாதிரி நிறையா a patient got a sudden chest pain and he was brought to the hospital, and the doctor was asking, anything bad news he had, why he is having such pain. That lady said, அவருடைய கார்டியாலஜிஸ்ட்டுக்கு மார்னிங் ஹார்ட் அட்டாக் வந்துருச்சுன்னு நியூஸ் வந்துச்சு, அதுலேருந்து இவருக்கு ஹார்ட் அட்டாக் வந்துச்சு டாக்டர் அப்படிங்கிறாராம். அந்த மாதிரி அப்புறம் நிறையா திங்ஸ். we want to emphasize the physical exercises, we have to tell the patient in a humorous way. And of course that cycling is very much important and very good exercise. To emphasize that, there is a joke in France. A doctor was walking on the road and he saw a 73-year-old man cycling for a long time. He asked him, what is the secret of your health? He said, morning full of cycling and night red wine. At what age your father died? The doctor asked. Died? No, he is 93 years. You see, he is cycling there. What is the secret? Cycling, red wine. Now the doctor was உஷாராயிட்டார். சரி, தாத்தாவை பற்றி கேட்கலான்னு சொல்லிட்டு, உங்கள் தாத்தாவும் சைக்கிளில் போயிட்டுருக்காரு அப்படின்னு கேட்டிருக்காரு. ஆமாம் போவார், பட் இன்றைக்கி அவர் வரல அப்படின்னு. ஒய்? அவருக்கு இன்னைக்கு கல்யாணம் அப்படின்னா. மேரேஜா? இந்த வயசில் அவர் அக்செப்ட் பண்ணிட்டாரா? ஆமாம், 10 years ஆயிடுச்சு. ஹி வாஸ் ஃபோர்ஸ்டு டு மேரி அப்படின்னா. ஃபோர்ஸ்டு டு மேரி, அவருடைய கேர்ள் ஃப்ரெண்ட் ப்ரெக்னென்ட் ஆகிட்டாங்க அப்படின்னாரு. It's too much. To have more of jokes, you should Osho's jokes, mullah stories, and so many social medias and everything. We have a lot of jokes. Let us enjoy the jokes, and at the same time, there is a time. I think the time will come in that there is the therapeutic humor will be coming into our practice. MD humor திருப்பின்னு கூட வந்தால் ஆச்சரியப்படுறதுக்குல்ல. அப்படி ஒன்று வந்ததுன்னா நான் ஜாயின் பண்ணிக்கலான்ட்டு இருக்கேன். தேங்க்யூ வெரி மச்.
Sir, thank you very much, sir. I kindly call upon Dr. Ravi sir to honor our guest speaker. we have come to the end of the meeting. I kindly call upon our treasurer, Dr. Arvind, to deliver the vote of thanks.
Good evening. On behalf of Erode IMA, I'd like to thank our speakers, Dr. Sendilvel sir from Maruti Medical Center, Dr. Suresh Babu sir, Dr. Vijay Kumar sir, Dr. Shakti Rajeshwari madam, and Dr. Rajavel sir for their excellent talk. On behalf of our foundation, we thank the IE Foundation for the sponsor. Before leaving, I request everybody to please register for Tamil Nadu Medical Council. Please give your correct details. Thank you. I request everybody to please stand up for national anthem. Thank you.